Right, good morning. So as was stated, I'm going to be talking about two conditions here, primary aldosteronism, and then a second section on pheochromocytoma and paraganglioma. I don't have anything to disclose. I'll start each segment with a case, and we'll use that case to build into the discussion. So here's the first case. 56-year-old man presents for evaluation of hypertension. He was diagnosed with high blood pressure more than 20 years ago in his early 30s. You can see his blood pressure was quite high at the time. He doesn't remember all the details, but was treated initially with a thiazide and then potentially other medications. He's had hypokalemia on a number of occasions, at least on one occasion as low as 3.0. He's had various workups before coming to see you, including abdominal cross-sectional imaging that showed normal adrenal glands. So this is him now, 20 years later. You're seeing him. He's still hypertensive most of the time, but he's on a lot of medications. He's on a thiazide. He's on a high dose of verapamil, calcium channel blocker, enalapril 20, a high dose of amiloride, 20 milligrams a day, hydralazine, and a little bit of potassium. You evaluate him on these medications, and you see his sodium is 142, his potassium is 3.8, bicarb is 24. His serum aldosterone is 49 nanograms per deciliter. Plasma renin activity is 1.7 nanograms per mil per hour. I calculated the aldosterone to renin ratio for you here, 29. Plasma metanephrines, normal. Dexamethasone suppression test to rule out hypercortisolism, also normal. So what do you think about this? Do you think this is a positive screen for primary aldosteronism? Do you think this is a negative screen, it excludes primary aldosteronism? Or do you think you need to repeat the testing after removing some potentially interfering medications, either the ACE inhibitor, thiazide, amiloride, or verapamil? And I'll let you contemplate this. There's a couple of ways you can answer this question, and you can make a debate for a variety of right answers. If you answered A, that this is a positive screen, even though I don't think that's the absolute right answer, it'll turn out you'll see that you are correct. You can make various arguments for which medication you want to wash out, but as I'll explain to you, one of the big interferers here is the amiloride, and you can consider stopping that and repeating testing, and since this is my patient, that's what I did. So his amiloride was stopped. In the meantime, he was treated with an alpha-1 antagonist, doxazosin, which is relatively neutral on renin-angiotensin-aldosterone physiology to make sure his blood pressure remained in a reasonable range. And you can see his labs 2.5 weeks later, sodium 144, potassium has dropped to 3.1, his bicarb has risen to 33, serum aldosterone 26 nanograms per deciliter, and you can see his renin activities, maybe the most important thing here, has dropped to an undetectable range, so it's 0. And depending on how you assign a number to the renin activity, his aldosterone-renin ratio is anywhere from 27 to infinity. Okay, so this is not only a positive screen for primary aldosteronism, these labs show you that this is a confirmed diagnosis, and you can seal the deal right there. Okay, so I'll come back to this case and explain what's going on, but let's first talk about what primary aldosteronism is, and I'll briefly review the physiology because, as you will see, for primary aldosteronism, this is a very physiology-driven diagnosis and management. So first, before we talk about primary aldosteronism, let's talk about aldosteronism in general. The most common forms of hyperaldosteronism are in fact physiology-based. We'll talk first about a renin-dependent aldosteronism, secondary to intravascular volume depletion. When we're volume depleted, the juxtaglomerular cells release renin, which activates the renin-angiotensin system and generates vasoactive peptide angiotensin II. This has multiple functions. First, it's a vasoconstrictor. When you're volume depleted, it helps maintain your blood pressure directly by vasoconstricting, and then it helps counter the intravascular volume depletion by instigating the reabsorption of sodium, mostly in the proximal tubule, and water follows with it for isotonic volume expansion. This is a very efficient process, so efficient that you decrease substantially the delivery of sodium to the distal nephron, and you need that little bit of extra sodium reabsorption in the distal nephron to live in the long term. So angiotensin II recruits a friend, and that friend is aldosterone. Angiotensin II stimulates the production and release of aldosterone from zona glomerulosa cells in the adrenal cortex. This aldosterone interacts with the mineralocorticoid receptor in the principal cell to induce ENaC-mediated sodium reabsorption. Water follows with aquaporins and ADH present, so there's more isotonic volume that's reabsorbed. And this process to maintain electroneutrality is paired with the excretion of a cation, which is either potassium or hydrogen ion acid. You don't want to become hypokalemic in this process, and there are a variety of ways to mitigate that. The first is, since potassium excretion is paired with sodium reabsorption, the decreased delivery of distal sodium will minimize how much potassium we excrete, and then there are some direct mechanisms mediated by angiotensin II in the principal cell and intercalated cells. So what's the net effect? This is a renin-dependent aldosteronism due to hypovolemia that results in an optimal or maximal sodium reabsorption to expand the volume and counter the original insult. And at the same time, you don't want to become hypokalemic, so you minimize potassium excretion. It's a pretty clever way to stay alive. Another physiologic hyperaldosteronism is a renin-independent hyperaldosteronism that's driven by extracellular hyperkalemia. And just imagine for a moment that volume is not an issue, your volume replete, such that renin is not stimulated and there's minimal or no production of angiotensin II. So in the absence of angiotensin II, you have a diminished reabsorption of sodium and volume proximally, which means there's more sodium delivered distally. So extracellular hyperkalemia or any potassium above the body's set point will independently stimulate aldosterone production in the ZG, and aldosterone will bind to the MR and increase ENaC-mediated sodium reabsorption for the purpose of increasing potassium excretion. And this will continue until the original stimulus, the hyperkalemia, is extinguished. I just point this out here just to show you how much of classical physiology is going to be changed in the future. Recent papers, and you can see the citation down here if you're interested, show that potassium can stimulate its own release through mechanisms that are independent of aldosterone, which is a pretty cool finding by Pierce's group in UCSF. So what's the net effect here? This is a renin-independent aldosterone production stimulated by extracellular hyperkalemia that results in optimal or maximal potassium excretion to neutralize the hyperkalemia, all while minimizing sodium reabsorption and volume expansion. Why should you expand your plasma volume when all you want to do is get rid of potassium? And of course, these two hyperaldosteronisms, due to volume depletion and hyperkalemia, can occur at the same time. You can be volume depleted and hyperkalemic and have two independent overlapping processes. So now, what is primary aldosteronism? This is a pathophysiology. It's a renin-independent aldosterone production despite a volume expanded state that should suppress it. So the primary problem here is that one or both adrenal glands have one or multiple foci that are autonomously producing aldosterone despite the absence of its secretagogues. So volume is expanded, renin and angiotensin II are suppressed, yet you still have production and secretion of aldosterone. So what happens here, you don't have angiotensin II around, so there's a diminished reabsorption of sodium and volume proximally, which means more is being delivered distally, which means all that sodium is being met by excessive aldosterone-MR interactions and increased ENaC reabsorption with volume and increased potassium and hydrogen ion excretion. That is a paired process with the sodium reabsorption. And this sets up a vicious cycle. You have increased delivery of sodium, you have increased sodium reabsorption, volume expansion, glomerular filtration, which results in more increased delivery of sodium, and so on and so forth. And because this process is paired with the excretion of potassium and hydrogen ion, you can get hypokalemic and alkalotic. So what is primary aldosteronism? It's a renin-independent aldosteronism that results in excessive activation of the renal mineralocorticoid receptor and a vicious cycle of volume expansion that results in increases in blood pressure or incident hypertension, increased potassium and hydrogen ion excretion, and it also increases the risk of cardiovascular disease, in part mediated through hypertension, which we all know is an independent risk factor for heart disease, but also independent of hypertension and high blood pressure via direct effects on the cardiac myocardial mineralocorticoid receptor, vascular and smooth muscle, endothelial and smooth muscle mineralocorticoid receptors. From a clinical standpoint, as a clinician, what are the hallmark biochemical features in your patient? Suppression of renin and angiotensin II if you were to measure it, and in the context of that renin suppression, a dysregulated or inappropriate production of aldosterone. So this is the physiologic basis, and then in a few slides I'll overlap what the clinical or practical cutoffs are. But if you understand the physiologic basis, the practical cutoffs you will see can vary quite a bit. Okay, so independent of blood pressure, MR activation in primary aldosteronism increases the risk for coronary artery disease, for stroke, heart failure, left ventricular hypertrophy, atrial fibrillation, and possibly also diabetes and metabolic syndrome. And because of this panoply of cardiometabolic disease that's associated, it's important to recognize this condition early, and you will see that there's a rash of underdiagnosis and underrecognition of primary aldosteronism. and initiate treatment, which we have. So how common is primary aldosteronism? In a word, very common. And you and I, we are all underdiagnosing this condition most likely. So there's a lot of ways to present this data. I'm just going to select a few studies that show you the tip of the iceberg on how common primary aldosteronism probably is. As a background, there are many studies in resistant hypertension. We'll start at the most severe form of hypertension that show overt primary aldosteronism occurs in resistant hypertension in about 10 to 25% of individuals with resistant hypertension, depending on the study you choose. But I'll show you that maybe the prevalence is even higher. And for that, I'll mention the Pathway 2 study, which you may have already heard about or will hear about in more detail in one of the other lectures. Pathway 2 is a study designed to evaluate what's the best fourth medication in resistant hypertension. So in patients with resistant hypertension who are already on a RAS inhibitor, diuretic, calcium channel blocker, and need better control, what's the best fourth agent? And in this study, patients were enrolled if they didn't have secondary hypertension, meaning a hypertension expert evaluated each patient and said, you don't have pheochromocytoma, you don't have primary aldosteronism, you don't have Cushing syndrome, etc. You have idiopathic or essential resistant hypertension. Then you were entered into this study, and you were randomized and crossed over to either an alpha blocker, doxazosin, beta blocker, bisoprolol, spironolactone, a mineralocorticoid receptor antagonist, or placebo, and each patient got every single one of these interventions. So what did they find? The primary finding was that spironolactone, a mineralocorticoid receptor antagonist, was the best fourth agent in resistant hypertension. It lowered blood pressure better than alpha antagonist, beta blocker, and of course placebo. When did spironolactone work best? So what you're looking at here is on the y-axis, the drop in systolic blood pressure, and on the x-axis, a log scale of renin. The red line is spironolactone. So what you see is spironolactone reduces blood pressure better when renin is lower. In fact, when the renin is fully suppressed, you have the greatest reduction in systolic blood pressure. It's kind of amazing. 15 to 20 millimeters of mercury of an additional blood pressure drop by adding spironolactone in resistant hypertension. Here's that data with aldosterone superimposed. Here you see the drop in systolic blood pressure to spironolactone, and on the x-axis, the log scales for renin, aldosterone, and aldosterone to renin ratio. And what you see is spironolactone reduces blood pressure the most when renin is suppressed, when aldosterone is highest, and naturally when the aldosterone to renin ratio is highest. Just as a reminder, these were patients with resistant hypertension that some hypertension expert deemed did not have primary aldosteronism. But what you're seeing is a reduction in blood pressure that's dominated by those who have a renin-independent hyperaldosteronism phenotype. So isn't this primary aldosteronism? What you're seeing is that a substantial proportion of patients thought to have idiopathic or essential resistant hypertension have a biochemical phenotype of renin-independent aldosterone production that responds preferentially to a mineralocorticoid receptor antagonist, in this case spironolactone. But this phenotype generally evaded, at least in this study, the current diagnostic standards for classifying primary aldosteronism. So even below what we recognize, there continues to be a spectrum of renin-independent aldosteronism or primary aldosteronism that's missed, but responds very well to an MR antagonist. Here's another way of looking at the problem. There are many studies like this. I'm picking one with better graphics. This is a study that systematically looked for primary aldosteronism. So every single consecutive patient to a hypertension center was evaluated in the same way. There's about 1,700 patients. None of them are on any medications. They're withdrawn of medications. And these investigators screened them for primary aldosteronism and used fixed criteria. If your aldosterone was greater than 10 nanograms per deciliter, aldo-renin ratio greater than 30, it was a yes. And if you screened positive, every single one of them had a confirmatory test, either a saline suppression test or a captopril challenge. They used fixed criteria. It's not important what the numbers are. And at the end of this study, they found that 6% of these consecutive hypertension referrals had overt primary aldosteronism. So more than the general prevalence, look at the distribution, which has been shown in study after study. If you had pretty severe hypertension, which would now be called, well into the stage 2 category based on your previous lecture, blood pressure is greater than 160 over 100, the prevalence was between 10 and 12%. Okay, and I call this overt or classical primary aldosteronism. You should have screened these patients for primary aldosteronism, and if you do systematically, 10 to 12% have classical primary aldosteronism. Here's a group of individuals who had milder hypertension, 140 to 159. Generally speaking, most of these individuals would have never been screened for primary aldosteronism outside of a systematic study like this, yet 4 to 5% of them have overt primary aldosteronism that would have otherwise been unrecognized. And you can go on study after study that shows the same distribution in primary aldosteronism recognition when you conduct systematic analyses like this. So who should you screen? These are the official recommendations from the Endocrine Society and similar societies. I'm just going to read them to you so you know what the official stance is. Anybody with severe or resistant hypertension that's defined as a blood pressure more than 150/100 on 3 occasions, 3 separate occasions, over 140/90 on 3 medications, or less than 140/90 but requiring 4 or more medications. So it's a pretty severe definition of hypertension. I think I and many other people, including the studies I briefly showed you and many others, would suggest that you should probably look for it way earlier, but this is what the official recommendation is. Anybody with hypertension and any form of hypokalemia, spontaneous or diuretic induced, hypertension with an adrenal mass, hypertension with sleep apnea, because that's been shown to be a population that is in a very high or enrichment for primary aldosteronism, and then anybody with a family history or a young onset of hypertension that concerns you for secondary hypertension. So the patient that I showed you had the really strong indications, very severe hypertension for a long period of time with multiple episodes of hypokalemia, certainly should have been screened. So despite these severe criteria, what I would say pretty high thresholds for screening, we do a pretty poor job in looking for primary aldosteronism. So this is just data from one large tertiary care center in the United States. The number of something like 40,000 people that were studied in this analysis, if the number of people who had a clear indication to be screened for primary aldosteronism, that's hypertension with hypokalemia, less than 3% had an aldosterone and renin measured to screen. And these weren't run-of-the-mill hypertension. Most of these patients had resistant hypertension and were still not screened. Of those with hypertension and sleep apnea, that number was even lower. So in short, we're not doing a good job looking, even based on the classical criteria that I think are fairly conservative. So you need to test more. When you do test, how should you screen? I think you all know this. The recommended screening test is an aldosterone to renin ratio. I would emphasize that you look at the individual components rather than the quotient or the ratio. That is, look at the renin and look at the aldosterone and use the physiology of the disease to try to convince yourself of whether it may or may not be present. And the reason I say that is there is no gold standard. Okay, there's no international consensus on how to define primary aldosteronism. There's no histopathologic gold standard to calibrate or validate a diagnostic like the aldosterone to renin ratio against, which means this is an unvalidated and an uncalibrated diagnostic. And the cutoffs that you use or that are recommended are arbitrary. Somebody made them up, and you can make them up also. Okay, so how do you do this? So based on the physiology I showed you, what are you looking for when you're looking for primary aldosteronism? You're looking for renin-independent aldosterone production despite a volume expanded state. So step 1 is the renin suppressed. If you use renin activity, suppressed renin, if it's undetectable, less than 0.6 nanograms per milliliter per hour, it's 0. That's a suppressed renin. Often, most people will say even a renin less than 1 is relatively suppressed and can be consistent with the diagnosis. If you use renin concentration, the rough equivalent of this is 10 nanograms per liter. But in addition to the suppression of renin, you want to see, quote, hyperaldosteronism. So what is that? Now, the higher the aldosterone, the higher the numerator, the more obvious the case is going to be, right? So if it's 25 nanograms per deciliter with a suppressed renin and hypertension, hypokalemia, anybody can make that diagnosis. The challenge is how low can the aldosterone be for it to still be a true case of primary aldosteronism? So there are various cutoffs, and this really depends philosophically on you and where you practice. The higher the cutoff you use, the more likely you're going to diagnose a case, but the more mild cases you're going to miss. The lower the cutoff you use, the more cases you will diagnose, but at the expense of more false positives. Okay, so it's a little bit of a philosophical issue as well as a cost issue and practical issue based on where you practice, but various cutoffs that have been proposed include 15, 10, 6, etc. The aldosterone to renin ratio is going to be high if the denominator is 0. So this is really more about which aldosterone value in the clinical context is enough for you to say, you know what, this is a positive screen, I want to do more testing to flush this out. What's a negative or uninterpretable screen? If you think someone has primary aldosteronism and the renin is not suppressed, like the case I showed you, that's really not consistent with the physiology that you expect. And if the aldosterone is not high enough for you to be convinced it's hyperaldosteronism, then that may not be consistent either. So are there problems with the aldosterone-renin ratio? I highlighted a few. Yes, there are many, but despite that, I would recommend, given the gross underdiagnosis of this condition, if the patient is sitting in front of you in clinic, go ahead and test. If the renin comes back suppressed, regardless of the medications that they're on, the aldosterone and aldosterone-renin ratio values are likely interpretable. And if they're not, then you can consider a potential false negative that you may need to address with a medication washout. Okay, so what are causes of false negatives? I'll highlight the main ones. The main problem you need to look for is a medication or condition that can raise the denominator of the aldosterone to renin ratio, that is renin or renin activity. And the two biggest culprits you might see are mineralocorticoid receptor antagonists or an ENaC inhibitor like amiloride. If you think about it, both of these treat the condition, right? If you block the MR or you block ENaC-mediated sodium reabsorption and contract the volume, you may raise renin and cause a false negative. Okay? The physiology may not be consistent because the disease is partially or completely treated. People often think an ACE inhibitor or an ARB may do this. In normal physiology, an ACE and ARB will raise renin. In the physiology of primary aldosteronism, which is a renin-independent aldosteronism, it really shouldn't do that. In fact, an ACE inhibitor failing to raise renin is one of the confirmatory tests. So rarely is that going to be a problem. Severe dietary sodium restriction, severe or aggressive diuresis and pregnancy are all states that can dramatically raise renin, but it takes a lot to do that. Are there false positives, something that can lower the denominator falsely, lower renin? Yes, the main one is a beta blocker, but if a beta blocker lowers renin, it's going to lower angiotensin II and aldosterone as well. And if the patient has primary aldosteronism, the aldosterone is not going to listen to the renin. So in general, the likelihood that you will have a false positive screen due to a beta blocker is low. So what's my general advice for screening? Be aware of the potential false negatives and positives, but go ahead and screen the patient in clinic. Don't defer the testing because this is something that's generally underdiagnosed. If the renin comes back suppressed regardless of the medications they're on, the results are likely to be interpretable and useful for you. Washing out medications, changing blood pressure medications in patients with primary aldosteronism who generally have pretty severe hypertension by the time you see them can be risky. It can take time, cumbersome. It requires patient compliance and communication, home blood pressure monitoring. I don't recommend it unless you really think you need to do it, and even when you do it, it can take days to weeks, as I showed you in that example. If the renin comes back unsuppressed and you really strongly suspect primary aldosteronism, like the patient I showed you, then you can consider a medication washout. How long do you have to wash out the medication? Long enough that you feel convinced that the renin has suppressed or is never going to suppress. So for patients who are on an MR antagonist or an ENaC inhibitor, that can take 2 to 6 weeks. So you might need to wait 1 to 2 months before you close the case. And if it doesn't suppress after that, you have to think about this not being a renin-independent aldosteronism. Rarely, in my opinion, do you ever need to wash out ACE inhibitors and ARBs. Personally, I never do that. Make sure the patient is on a high sodium diet. That's usually not an issue. And if the renin doesn't suppress after 2 months, you need to think about alternative diagnoses. What should you do if you conduct a washout? Don't leave the blood pressure sky high. You can use a variety of other antihypertensives in the meantime that are relatively neutral on aldosterone physiology and on renin physiology. My preferred one is an alpha-1 antagonist, doxazosin. You can also use hydralazine and verapamil if you prefer. So coming back to this question, this was a patient with long-standing resistant hypertension, hypokalemia. Your pretest probability for primary aldosteronism was very high. When you tested, the renin came back at 1.7, which is reasonably normal or high renin activity and not consistent with primary aldosteronism. But this patient was taking 20 milligrams of amiloride, and when you stopped it, you quickly saw that within 2 weeks, his potassium dropped, he became alkalotic, and his renin was suppressed. So this is just an example of the physiology and treatment of primary aldosteronism. So a few words on confirmation and localization. What's the value of a confirmatory test? It's the screening test. If it's not very obvious, a confirmatory test is generally a dynamic or physiologic way to convince you that there is truly renin-independent and autonomous aldosterone production. Again, just like the aldosterone to renin ratio, there is no gold standard for confirmatory tests. All of these confirmatory tests are relatively arbitrary. They make physiologic sense, but there are no validated or calibrated cutoffs. So each one is used with some varying degree of diagnostic accuracy. Almost all of them involve sodium or volume expansion and therefore increase the risk of worsening blood pressure and or hypokalemia. So do these with caution and close supervision. The easiest one is if you don't have to do a dynamic confirmatory test. If your patient has hypertension, hypokalemia, a very high aldosterone level, and a completely suppressed renin, there's nothing else this could be. So the case I showed you after you washed out amiloride, it was a slam dunk. Nothing further needs to be done. If the case is not as obvious, you may want to convince yourself further by doing a variety of suppression tests, and you can load the patient with oral sodium for several days. You can do an intravenous, which is a relatively acute saline suppression test, fludrocortisone suppression test, captopril suppression or challenge test, and there are others, believe it or not. I'm not going to go over the protocols because the protocols vary from place to place, and the interpretation of each test has a variable degree of heterogeneity as well. So you should do whichever one you can conduct in your personal institutions with confidence and safety monitoring. A word about localization. The key thing is localization should follow biochemical confirmation. You can have primary aldosteronism with normal-looking adrenal glands, and you can have incidental adrenal adenomas on one or both sides. So cross-sectional imaging is something that we do to get a roadmap of what's going on, but rarely is it diagnostic. Okay, so diagnose the patient biochemically, and then you perform cross-sectional imaging to get a lay of the land, and in almost every scenario, adrenal venous sampling should be considered. I'm not going to go through all the data on adrenal venous sampling, but just so you know, almost every society and expert recommends adrenal venous sampling when available. In almost every scenario, the main caveat is if your patient is very young, and you can define young in a variety of ways, but under 30 to 40, with pretty obvious primary aldosteronism, hypertension, hypokalemia, and a clear-cut unilateral adenoma, the likelihood that that is the culprit is high enough that you can skip adrenal venous sampling. For almost every other scenario, adrenal venous sampling is recommended. So going back to our case, he was confirmed to have primary aldosteronism as we discussed. This is his CT scan. You can see his adrenal glands left and right. Both of them have no adenomas or obvious hyperplasia. Maybe the left side is diffusely thickened if you really squint, but this is a pretty unremarkable scan of the adrenal glands. This does not exclude primary aldosteronism. So the classic textbook discussions about adenoma or bilateral hyperplasia, those are severe and classic cases, but you can see primary aldosteronism even when the adrenal glands look relatively normal on cross-sectional imaging. This patient had an adrenal venous sampling that showed that both sides were overproducing aldosterone, so he was diagnosed with bilateral primary aldosteronism, and he was treated medically with a mineralocorticoid receptor antagonist, in this case eplerenone, and his hypertensive regimen was consolidated to eplerenone, amlodipine, hydrochlorothiazide, and you can see his blood pressure is reasonable, 132/77. He still has primary aldosteronism. His aldosterone is 22, his renin is still suppressed, less than assay, and his potassium is better controlled. So is his medical treatment optimized? And the answer to that question is another question. What is the goal when you treat somebody for primary aldosteronism with a mineralocorticoid receptor antagonist? Is it to normalize the blood pressure, normalize the potassium, reduce cardiovascular risk, increase renin as a measure of treatment efficacy, or all of the above? Probably all of the above. So just a brief word on treatment. This is the classic treatment dogma that has littered textbooks for decades, which is that when the disease is unilateral, you should perform a curative surgical adrenalectomy. But if the disease is bilateral, avoid surgery and treat the patient forever with a mineralocorticoid receptor antagonist. And generally speaking, these two were equated as with equal efficacy. Okay, there was never been a randomized controlled trial to show that, but generally speaking, patients were counseled that you can do either or and you're going to get the same outcome. And it turns out that's probably not true. Just to give you a couple of examples of how that might be the case, we still don't have a randomized controlled trial. We only have longitudinal cohort studies. This is one of them. This shows incident cardiovascular events, MI, heart failure, stroke. And in red, you see patients with primary aldosteronism treated longitudinally with a mineralocorticoid receptor antagonist. In green, you see patients who are treated for unilateral primary aldosteronism with a curative adrenalectomy. And in blue are matched patients with essential hypertension who did not have primary aldosteronism. And what you see is medical therapy is associated with a much higher incident event rate, whereas curative adrenalectomy is associated with a slightly lower event rate. Here's the same cohort of patients with incident CKD. On the y-axis, you see eGFR. Actually, on the left here, you see the pre-treatment. You can see patients with primary aldosteronism actually have higher GFRs than patients with essential hypertension, probably reflective of volume expansion and hyperfiltration. The minute you treat them, their first GFR after treatment actually drops precipitously. And over time, what you're seeing here is patients with essential hypertension and curative adrenalectomy have a similar age or time-dependent decline in GFR, but patients treated medically have a much steeper and higher magnitude decline in GFR. So why might this be the case? I'm just going to come back to the physiology of primary aldosteronism and overlay a variety of treatments. So what are the options for treatment? Before pharmacologic treatment, actually dietary sodium restriction is extremely effective. It's to be recommended in all patients with hypertension, but it's particularly effective in primary aldosteronism, which should make sense. This is the dominant fuel, if you want to say, for the volume expansion. If you successfully restrict dietary sodium intake, you'll decrease how much sodium is reabsorbed. And if you restrict it enough, you'll actually contract the volume and renin will rise. It'll go from being suppressed to unsuppressed. You can achieve something similar with the mineralocorticoid receptor antagonist. You block the MR, you reduce ENaC-mediated sodium reabsorption and volume expansion, and if you do this successfully, you'll actually contract the volume expansion and the JG cells will start secreting renin again. So the rise in renin and angiotensin II is a sign of adequate MR blockade. And of course, you can physically remove the source of aldosterone production and achieve the same effect. So what happens when you treat primary aldosteronism effectively? You decrease ENaC-mediated sodium reabsorption, you consequently reduce potassium and hydrogen ion excretion. If you do a good job at this, you'll contract the intravascular volume, and one biomarker or surrogate proxy for that is an increase or normalization of the renin that was previously suppressed. So here's the same data I showed you. Now these patients are stratified by the renin that was achieved with medical therapy. And what you see is if you had primary aldosteronism that was treated with a mineralocorticoid receptor antagonist, but your renin remains suppressed throughout your treatment time, that's the population that had the higher risk in cardiovascular events. On the other hand, if you had primary aldosteronism that was treated medically such that the renin rose, it went from being suppressed to unsuppressed, the risk of incident cardiovascular events was similar to age and otherwise matched patients without primary aldosteronism. And this effect seemed to be independent of blood pressure. Patients who had a rise in renin or had their renin remain suppressed had relatively similar blood pressures. So this was an effect that seems to be mediated straight through the mineralocorticoid receptor antagonism more so than blood pressure. So the current and recommended practice of lifelong MR antagonist therapy in primary aldosteronism is associated with a higher risk of incident cardiovascular events. I didn't show you this: death, chronic kidney disease, and it seems to be independent of gross changes in blood pressure compared to matched patients with hypertension. However, you can use a rise in renin as a biomarker or proxy for sufficient volume contraction and or MR antagonism, and that is associated with a lower risk of incident events. But I will tell you that's not always possible. I would say in about 2/3 of my patients, I'm able to achieve a substantial rise in renin, and in about 1/3, it's harder to do. Why? Sometimes patients can't tolerate mineralocorticoid receptor antagonists. Sometimes you run into CKD and recurrent hyperkalemia that prevents you from being aggressive. Beta blockers lower renin, and patients on high doses of beta blockers, you may not be able to see that rise in renin. It just may not be a good biomarker in those patients. And then sometimes you can't tell why it's not working. But if this type of data makes you more aggressive with an MR antagonist, it seems to be probably for the best in the patient's interest for incident cardiovascular risk. On the other hand, surgical therapy to cure or attenuate the severity of primary aldosteronism may mitigate these risks more effectively. So more questions, more future studies. How do you candidly counsel your patients about lifelong MR antagonist therapy and the efficacy and future risk associated with this decision? Is the current treatment dogma as a binary form still appropriate? Probably not, probably needs to be revised further. Should surgical adrenalectomy be considered more frequently? Probably yes. And this is just my thoughts summed up for you in an algorithm. You suspect primary aldosteronism, you should try to suspect it more. You're underdiagnosing it. When you go to screen for it, you measure an aldosterone and a renin. Think physiologically, you want to see the renin suppressed, and in the context of renin suppression, you want to see an inappropriately high aldosterone value such that the aldosterone to renin ratio is high because the denominator is very close to 0. Once you have a positive screen, you can proceed with confirmation. However, if the patient has clear-cut primary aldosteronism, meaning hypertension, hypokalemia, a suppressed renin, and a very high aldosterone, that is sufficient to confirm the diagnosis, and no further dynamic tests are needed. Otherwise, you can use a variety of dynamic confirmatory tests that I mentioned. And once the diagnosis is confirmed, then you can proceed with localization, initially with cross-sectional imaging, and then with adrenal venous sampling. If your patient is not interested in surgery at all, or is unable, too sick to undergo surgery, you don't need to proceed with localization and adrenal venous sampling. Some recommend that you should still get a CT to exclude the very rare possibility that this primary aldosteronism is driven by an adrenocortical carcinoma, but otherwise you can just jump to medical therapy with an MR antagonist. Otherwise, you will pursue adrenal venous sampling. The one time you can skip adrenal venous sampling is in severe cases of overt primary aldosteronism in very young patients who have a clear-cut unilateral adenoma. There, the likelihood that that's the culprit is so high, you don't need an adrenal venous sampling, and you can proceed with a unilateral laparoscopic adrenalectomy. Otherwise, the adrenal venous sampling will guide you. Unilateral cases, a surgical adrenalectomy will cure the aldosterone excess, will substantially improve, sometimes even cure the high blood pressure and hypokalemia, and it will lower cardiovascular risk. Otherwise, you'll use MR antagonist therapy plus other lifestyle changes like dietary sodium restriction with the goals of normalizing blood pressure, hypokalemia, lowering overall cardiovascular risk, and an attempt to raise renin as a proxy that you've done a good job. Now, sometimes you're unable to control blood pressure or hypokalemia with an MR antagonist. The patient has CKD that limits your ability to aggressively titrate the MR antagonist. You're running into hyperkalemia. The patient has very high cardiovascular risk, maybe even number of cardiovascular events and a suppressed renin, and or there's grossly asymmetric bilateral disease. The adrenal venous sampling shows that one side is making 4 times the aldosterone as the other. These are all case-by-case scenarios where you can consider a non-curative unilateral adrenalectomy, not to cure the primary aldosteronism, but to attenuate the severity of disease, lower future cardiovascular risk. And this is an individualized decision you can make on a case-by-case basis. So to summarize this section on primary aldosteronism, it's not a categorical or binary condition, and it's not rare. It exists across a large severity spectrum. We're probably only diagnosing the most severe cases at the tip of the iceberg. Screen and consider this diagnosis more. In contrast to surgical adrenalectomy, the way we currently practice lifelong MR antagonist therapy is associated with a much higher risk for incident cardiometabolic events, kidney disease, and death, and this seems to be independent of blood pressure. However, if you target a rise in renin, either with dietary sodium restriction and MR antagonist or the combo, or you use surgery more to attenuate the excess aldosterone, you can mitigate that risk. Okay, in the last 10 minutes or so, I'm going to go over pheochromocytoma and paraganglioma. So what are pheochromocytoma and paraganglioma? Some semantic definitions. A pheochromocytoma is a neuroendocrine tumor that arises from the adrenal medulla, and a paraganglioma is extraadrenal. It arises from the ganglia of the sympathetic or parasympathetic system. We'll really talk about the sympathetic nervous system since those are the functional ones. So this can occur in the neck, the chest or mediastinum, the abdomen, or the pelvis. Besides this anatomy or geography, there are some other functional differences between pheochromocytoma and paraganglioma. This is the catecholamine synthesis pathway from tyrosine. We make levodopa, and then the catecholamines dopamine to norepi to epi. The adrenal medulla can produce all of these, all the way to epinephrine. However, the sympathetic nervous system only has the enzymatic machinery to produce up to norepinephrine. In other words, only the adrenal medulla can make epinephrine. Now, don't measure plasma catecholamines. These exist in a very small concentration and have a very short half-life. Instead, you should measure the stable intermediates of catecholamines. That is, metanephrine, which is the metabolite of epinephrine, or normetanephrine, which is the metabolite of norepinephrine. These are inactive metabolites with a long half-life and that are very sensitive and specific. You can think of these like a hemoglobin A1C, and the catecholamines more like a glucose, which are much more labile. These metanephrines are also conjugated and excreted in the urine, so you can measure them in the blood, in the plasma, or in the urine. So this is just a cartoon that highlights this. This is an adrenal medullary cell. This is a sympathetic ganglion or nervous system cell, and this is a non-neuronal cell, and this is the blood. The adrenal medulla does secrete norepinephrine, but the vast majority of norepinephrine in your blood right now is coming from your sympathetic nervous system. which means the vast majority of the normetanephrine in your blood, which you'll use for diagnostic purposes, is actually coming from your sympathetic nervous system, not from the adrenal medulla. On the other hand, 100% of the epinephrine in your blood right now is coming from your adrenal medulla, which also means 100% of the metanephrine in your blood is sourced back to the adrenal medulla. So in other words, if you see elevations in metanephrine fraction, it's an adrenal medullary source. If you see elevations in the normetanephrine fraction, it could be coming from either the adrenal medulla or the sympathetic nervous system. So who should you evaluate for pheochromocytoma, paraganglioma? These are the official recommendations. Anyone with paroxysmal constellation of hyperadrenergic signs or symptoms, palpitations, sweating, anxiety, panic episodes, if they're measuring their blood pressure, elevations in blood pressure. Any provocation of these symptoms by anything, these are just some examples of events that can provoke a catecholamine crisis, the induction of anesthesia, and a variety of medications that have been associated with this. Anybody with an incidentally discovered adrenal mass that is not lipid-rich, and then anybody with either a known genetic predisposition or a concerning family history for pheochromocytoma and or paraganglioma. When you go to test, it's actually much easier than people think. You can use plasma-free fractionated metanephrines or a 24-hour urine collection. They're both excellent. One is much easier. Plasma metanephrines is a venipuncture, done. I would strongly recommend you use that rather than using 24-hour urine collections, which are a pain in the butt for patients to do, and there's a lot of compliance and adherence required. They both have near 100% sensitivity, so you're not going to miss true cases. The specificity is a little bit lower, 85 to 90%, which means 10 to 15% of individuals who do not have a pheo or paraganglioma will have a positive biochemistry. And what positive means, this is a false positive, is that there's a slight elevation above the upper limit of the reference range. But you're not looking for a slight elevation. Symptomatic pheochromocytomas and paragangliomas have substantial elevations above the upper limit of the reference range, 5-fold, 10-fold, but at least 2, 3, 4-fold. Okay, so you're looking for dramatic elevations, knowing that false positives occur not too infrequently with slight elevations above the upper limit of the reference range. So what can cause a false positive? On the left, you see an adrenal medullary cell or a presynaptic sympathetic neuron. On the right is an end organ cell or a postsynaptic sympathetic neuron. Any increase in sympathetic tone, stress, anxiety, critical illness can increase catecholamine levels. The use of a sympathomimetic, levodopa, or if your patient is in the ICU receiving an infusion of dopamine, norepinephrine or epinephrine, will increase catecholamines. You'll be surprised about how many consults we get on patients getting an infusion of a pressor. Monoamine oxidase inhibitors metabolize catecholamines. MAO inhibitors for depression are rarely used, but if your patient is using one, that can cause an increase in catecholamines. Once these catecholamines are secreted by the adrenal medulla or a sympathetic neuron, most of it is taken back up onto the presynaptic side or back into the adrenal medulla through a reuptake mechanism. This is a major source of false positives. Anything that blocks the reuptake of catecholamines can cause an elevation in metanephrines. Cocaine, tricyclic antidepressants, norepinephrine or epinephrine reuptake inhibitors, venlafaxine, bupropion, even serotonin reuptake inhibitors, which are very commonly used. Maybe 50% of patients I see are on one of these medications. In theory, an adrenergic receptor antagonist can do this also, although I've never seen a case. So I'm emphasizing false positives because you'll see false positive elevations probably more commonly than a true case. Things that can cause a false positive: extreme stress, critical illness, hospitalization, even non-supine posture, just sitting upright increases sympathoadrenergic tone. Most metanephrine assays are LC tandem mass spec. There's very little assay interference, if any at all, but physiologic interference can occur. The use of a sympathomimetic, but mostly reuptake inhibitors, cocaine, tricyclic antidepressants, or catecholamine reuptake inhibitors used for depression. And finally, severely impaired renal clearance. If the GFR is very low, this can impair the clearance of metanephrines in the urine, so the 24-hour urinary metanephrines can sometimes be falsely elevated, but the same will not be true for the plasma metanephrines, which is another reason to use the plasma metanephrine assay. This is just a cartoon highlighting that. This gray bar shows the reference range for metanephrines, and these are multiples of the upper limit of the reference range. Someone with a true symptomatic pheochromocytoma and paraganglioma will have substantial elevations above the upper limit of reference, at least 2-fold or greater. A false positive due to increased sympathoadrenergic drive or a reuptake inhibition mechanism will generally cause milder elevations between 1 and 2-fold above the upper limit of reference. And the negative predictive value of this test is close to 100%. So if the metanephrines return normal, you can exclude the diagnosis. All right, so just a quick case to show you what this looks like. Here's a 28-year woman, healthy and athletic, no known diagnoses, surgeries, or medications, runs 6 to 8 miles a day without difficulty, so stress testing herself, works as a real estate broker, but she's been complaining of sweating for the last 6 months. Just sitting at her desk, she soaks through her clothes. She even brings an extra change of dry clothes in the middle of the day. She feels anxious all the time, like she's been drinking a lot of caffeine. No triggers for this. She just thinks she's a sweaty, nervous person. Okay, no palpitations, chest pains, tremors. She's never checked her blood pressure, but in clinic it's 144/90. Okay, so this is not what you think about when you think about pheochromocytoma. This is not a hyperadrenergic crisis, but if you wait long enough, it will be. Okay, this is somebody with hyperadrenergic symptoms that just seem odd, and if you screen this person, this is what you get. Plasma metanephrine fraction, normal. Plasma normetanephrine fraction, about 7-fold elevated. Okay, so this is a biochemical confirmation of a catecholamine-producing tumor. And here is the 24-hour urine collection. If you wanted to do it, it shows a similar pattern. The normetanephrine fraction is elevated. So this is either a functional pheo or an extra-adrenal paraganglioma. The number one place to look is in the abdomen, and she actually has a right adrenal mass with a high density that looks like a pheochromocytoma. I won't go through the whole preoperative management, but this was surgically removed, and postoperatively, all of her sweats and anxiety completely resolved, her blood pressure resolved. So this is a functional pheochromocytoma caught before emergency room visit. The last slide I will show you is so much has changed in the genetics of pheochromocytoma and paraganglioma. I won't go through all of the details, but you should just be aware that this used to be considered a sporadic, benign, and non-familial condition. And probably when the majority of you went to medical school, you were taught that pheochromocytomas are generally sporadic, but rarely they're familial or malignant. In the last 15 years, we've discovered approximately 1 new germline mutation explaining these per year, such that around 35 to 40% of all pheochromocytomas can now be attributed to a known inheritable genetic mutation that not only increases the risk of pheo and paraganglioma, but sometimes other tumors, including renal cell carcinoma, gastrointestinal stromal tumors, and other neuroendocrine tumors. So for that reason, every patient with one of these tumors should be offered genetic testing. So to summarize this point, develop a pretest probability and understand the potential false positives when you screen for pheochromocytoma. You can use either plasma or urinary metanephrines. I would highly recommend plasma metanephrines, very sensitive, slightly less specific, but a true positive is a substantial elevation, multifold elevation above the upper limit of reference. And every patient with a pheo or paraganglia should be offered genetic testing. That's it. Thank you.